All right. Allow me to introduce to you Adam Faiz, a young boy who is about maybe 9 to 10 years old by now. And he's like the other children, able to go with the usual activities, going to school, go for holidays, and now he managed to win awards there, in the sports competitions. But 7 years ago, Adam Faiz was born as a Crouzon syndrome, okay? And it was not what it seems that he's going through now. All right, this was Adam Faiz 7 years ago when he came to our clinic, when he was about 2 years old. He got his eyeball is popping out, and his face is very much retruded backwards, not able to grow forward. This is syndrome where it doesn't allow our face to move forward because our partition in the skull, they fuse. And our skull not able to expand in all dimensions. So his eye keep growing, but the socket does not grow, so his eyes bulges out. And there is no space behind his nose that allow the air to flow into the lung. And he could not breathe. At this time when he came to our clinic, he every time he dozed off, he turned blue. He could not able to breathe. So he got a very well-trained maid by the parents, and every time he turned blue, the maid will shake him and he wake him up. So he could not sleep properly, and then he's got global development delay. He's not growing up very well. And we tried to find a solution for this problem. So we just have an idea what we're going to do with this patient. What we in our mind was we have to move his face forward. We have to move his face forward to accommodate the eye and to allow an airway behind that, allow air to flow into the lung. So this is we call it virtual surgery, where we can build a 3D model from the patient's CT scan, and we can make into 3 dimensions, and we can use whatever software we had at that time, we can slice it and move it forward. Basically, what we need to do here is that we have to cut the anterior part of the skull, and then we have to move and the measurement is about 30 millimeters. And at that time, the science does not achieve that far. I mean, no human faces, human skeleton being moved forward 30 millimeter. So with this predicted software that we do here, we managed to quantify, and we will see that when we move this forward by 30 millimeters, is adequate for the socket to accommodate the eyeball, and also allow some space behind the nose to allow the air to enter the lung. Then another technology that we have at the time is 3D printing. So this 3D printing can produce a life-size model, very much almost less than 1 millimeter accuracy, that we can really do some work on it. We can do some simulation on surgery, and we can try and error. And good thing here is that we are doing a special technique called distraction osteogenesis, which using this device. Here there's quite a scary device here that anchor to the head, and this device gonna anchor to the part of the anterior part of the face, and we're gonna pull the face forward. And there's another device here that you're going to put inside, and this is going to push the face forward after it being cut. So this movement is about 1 millimeter a day. When we do that, when the bone is separate apart, it becomes the blood clot behind it becomes like a chewing gum, and it becomes sticky. And when we move forward, it doesn't break off. And when we achieve the right amount, and we keep the same position for about 6 months, the bone will form between, and it produces a very, very stable bone. So this is distraction osteogenesis. Here, the good thing about this 3D printing that we can simulate. Before this, we don't have this technology. We are doing just eyeballing, and we cannot set a right direction where the face is going to move. And intraoperatively, we have to do a try and error, and sometimes if we don't do it right, it can move the wrong direction. same as the other device that going to push the face. So with this, we have saved the operating time for about 2 to 3 hours. That was the patient. So we do the surgery, we cut the face, the skeletal bone, and this was the first time that we put a device on the 2-year-old boy, and we doesn't know what we got up to. But thank God the patients accommodated very well. It's just that sometimes when he fully recovered from the surgery, when the sibling tease him, he tends to strike just like a horn. So it's quite dangerous. That make of metal, so it might injure the other sibling. So that was the patient. If you can see the progress before the surgery, when we start doing the surgery, the patient is wearing the device and it doesn't interfere with daily life. You know, he just can move about. We can send the patient home. That was the patient immediately after we removed the distractor, and that was 8 months after the surgery. Now it's 18 months, and we could see that here we have closed. Before he used to breathe to the whole of the neck, and with this surgery we allow him to breathe normally through the nose. Yeah, and this is actually we have achieved at this time. We achieved the largest movement worldwide that 30 millimeter ever achieved. We are very proud of it, and we go for a press release there. Came out in local newspaper, and then we share this with people from all over the world. All right, and over the years, from 2012 to now, we have done quite a number of cases using the same technology, and it really helped us, and we have grown wiser with it. And this among the patients that we do. This is also, we used to receive a patient from outside as well. This is from Somalia. Yeah? It was before the surgery, and that was after surgery. Same problem with the same technology, and we have published our case series in the international journal to share our experience. All right, and this also can be done on the lower jaw. Just another example. That was the lower jaw that we need to grow forward because this patient had born with a very, very small lower jaw. And he also could not breathe because the tongue kept falling backwards and blocking the airway, and he have to breathe through the hole at the neck. And the intention is the same here. We want to advance the jaw forward, and we use this to check the direction. We call it the vector, so that it goes in the same direction, and we can check also the amount of movement that we want to achieve. So at the end of the day, after 2 sessions of the dissection, we could see that the patient have a nice chin formation, and this patient is yet to just to close the hole in the neck. All right, moving on. This is we also utilize the virtual reality technology in our reconstruction surgery. And our face is the most exposed part of the body that always been exposed to the public scrutiny. So any discrepancy of the face more than 2 millimeters is visible to naked eye. And to achieve the maximum accuracy, any reconstruction, any reposition of the missing part or displaced part of the human face, if you want to put it back into the original position, we have to replace it back in the place where it's correct in the 3-dimensional coordinate. So anything lesser than that, then we were visible, the discrepancy is visible to the naked eye. All right, this is example of a disease on the lower jaw. Yeah? We call it a mandible. The lower jaw having disease is common disease, a common tumor called ameloblastoma. It's affecting quite a large population of Malaysians. So this diseased jaw can be sliced off by the computer, and we mirror the normal side to the abnormal side, and then we have the virtually reconstruct mandible. The same cases where we have a disease of the jaw, yeah? All the bone being destroyed by the tumor. And this, our computer expert, it's not our artificial intelligence expert, this is our postgraduate student who learned this trick, you know, and managed to do it. They just slice it off with our software available at the open source and managed to replace this missing part with a simulated bone from the leg called fibula. So they can have a 3D imaging of the leg that can replace this part, and then they can slice off and place it as a reconstructed lower jaw. All right, this is the planning to make, we call it a guide or jigs or cutting guide, so that the surgeon can take this blue color piece of jig here and put in the patient's jaw during the surgery and cut where it's marked. And then this is show how we slices the bone from the leg into 3 pieces to get a correct contour. These slices is then being guided by these virtually produced jigs, yeah, that have a hole there that allow the saw to go through and make the cut. So this is a computer-aided reconstruction of the lower jaw. That was the patient before and after the surgery, and that was the patient X-ray post-operatively to show the healing bone from the leg. All right, this is another case to show reconstruction of the face using the computer. This patient is most of the patient that we have with road traffic accident in Malaysia. We have quite a large number of road traffic accidents, unfortunately. And this is one of the motorcyclists hit by lorry. He was very happy to be alive, but then when he go home, children could not recognize him and they stayed away from him. So he came back to my clinic and asked me for if anything that could be done to his deformed face. So what we do here is we do, at the time, this was about 5-6 years ago, that we don't have a software that we have today. So we just mirror the normal side to the abnormal side. And then that's what we got, okay? Because the defect crossed the midline, we have a central defect. That's why I call it a missing centerpiece. So with that, we're using art and science together. We managed to use a thermoplastic material with a hand dryer, with a hair dryer, and soften that part and mold it artistically to represent the missing part, and we finally come up with a final prototype. And this was transferred into a mold, and we compressed a titanium sheet in between these 2 molds, keep it overnight, and managed to get a final shape of the missing part of the patient's bone. And we place it, that is a post-operative X-ray, show that the symmetry that had been achieved by the reconstructed part. That was the reconstructed part of the face, replaced totally by titanium, and we could see that it can be of acceptable symmetry with the normal side. And that was the compared patient pre and post-operatively. And over the years, we have developed a new software that we don't have to mirror anymore. This is called a tangential growth, that we can grow a new part of the body, new part of the missing bone, just by the software alone. That's the red colored is show that the missing part of the body that has been grown by the software itself. Then we managed to establish this process, yeah, from the 3D printing model with a defect, and then we developed the prototype and moved into a mold, and then that was the shaped titanium ready to be placed by the surgeon on the missing part of the scalp. And we managed to do a clinical trial on 20 patients with a Techno Fund. Thank you to the MOSTI for granting us the grant. And out of this clinical trial, we found that it's quite successful. Only 2 of the patients developed infection. That was a patient with irradiated, and the other one is medically compromised. And 90% of the patient agreed that the surgery was almost perfect. And this is among the few patients, samples of the clinical trial. We could see that we could achieve a nice symmetry after the face being built up. Another patient with the same problems. You could see that before and after. And this is another application that we use for the 3D printing. We managed to develop a biometric model that represents the anatomy of the scalp bone, and also the brain. And this is used for the training of the neurosurgeons. And this model now been sold in the US and Korea and Japan as well for the training of neurosurgeons, and is featured in our YouTube in the New Science. And this model is identified as the actual patient by our navigation system. Here is our surgeons doing the training of navigation surgery. And we move on to build another model. This is for oral maxillofacial surgeons to do arthroscopic surgery for the lower jaw joint, where we can put a scope inside, and it just like exactly represent the exact anatomy of actual human being joint. And before this, we use cadavers. We use cadavers, which are very much more expensive. To conclude, our experience in using the virtual reality technique in facilitating our daily surgery, we found that it's very, very useful, especially in terms of treatment outcomes. It gives better treatment outcomes, more symmetry compared to conventional technique, and also it have, to some extent, have shortened our operating time. And in case of, we could say that the mean operating time by using technology is about 2 to 3 hours compared to the conventional surgery. But of course, there's much more things to be done. It's keep on moving, the technology keep on moving, and I think we could use a bit more of the facilities to bring our craniofacial surgery to greater heights. And this is the future where now we are hunting for the right material to replace the missing part, to be as, we call it scaffolding, where any diseased part of the lower jaw, when we remove, we just put a right material that we can implant stem cell inside, that we can harvest their own cell, and finally this will grow into the normal mandible, just like before the disease. Just, I must say that our craniofacial team in the USIM layer is very committed, and with their commitment, and they always give their heart and minds together. With that, we managed to march across the clinical boundary. With that, I thank you very much for your kind attention.